Welcome. Good afternoon. And I'm Dr. Lisa Cooper. I'm the director of the Center, Johns Hopkins Center for Health Equity. And I'm actually joined by Reverend Deborah Hickman, who is co-chair of our Community Advisory Board, in leading you through the beginning of this meeting today. So welcome to part 2 of our end of study Rich Life Town Hall meeting. And today's meeting is going to be focused on the blood pressure and system level leader intervention programs. So we are so pleased that each of you have made time to be with us today. We have a very diverse group here of participants, community members, health professionals, researchers, health system leaders, trainees, staff, and hopefully we have some funders as well and other community-based organization representatives on the line. All right, so now we're going to move into just the overview, a brief recap of the first town hall meeting and overview of the Rich Life Project. So let's talk a little bit more about the standard of care plus arm of the trial, because we're going to hear a lot more about what happened there and some of the process measures from that today. So we randomly assigned each of the 30 practices to either the standard of care plus group or the collaborative care stepped care group. Now, at all of our sites, our staff members at clinical sites were trained in how to correctly measure blood pressure using this standardized blood pressure measurement training. They were also invited to take part in a 4-part web-based training about taking care of people with high blood pressure, called the Hypertension Care and Best Practices Training. We gave feedback to the clinicians and their staff members about how well their patients' blood pressure was being kept at a healthy level using something that we called a dashboard that showed the patient panels divided by race and ethnicity as well as overall. And then we also included a training program for health system leaders and practice champions, which was really more of a learning network than a training program per se, because we know a lot of people have expertise already, but we got them together to learn from each other and also to learn about best practices related to leading for health equity. So now the other half of the practices, so 15 of them, in addition to receiving all the things that I just talked about, also had exposure to the nurse care manager piece. And for these practices, the dashboard information that they got was facilitated by champions. So they got a little bit of extra in the way of sort of support and resources. Their clinic champions also went to some additional leadership training through monthly coaching calls, which then moved to sort of twice per quarter and then once per quarter. The collaborative care program included the nurse care managers, again, as I mentioned before, and the community health workers, and the opportunity to have the patient's case reviewed by specialists. So this program, the blood pressure measurement program, the aim of it was to standardize how blood pressure is measured across all of the Rich Life practices. And there was a protocol that we introduced called Screen and Confirm. We introduced automated blood pressure measurement devices to all the practices, and then all the staff were trained in how to measure blood pressure correctly, basically how to screen people initially, and then if they had an elevated reading on the first reading, to then confirm it using the specialized machine that actually incorporates a wait time into the measurement process, and then measurement of 3 separate measures, and then calculating the average measure. So it was launched in October of 2017. And again, I've already told you what the objectives were. So, but we did really want to do an observation period. And so this is what I'm talking about when we say fidelity audit. We really wanted to begin observing how well the practices were using the blood pressure measurement process. And so we wanted to also identify if there were any issues. And so now we'll move to the next slide. And so the Helm really had a kickoff session in September of 2016. And then there were 4 modules consisting of 17 sessions. So you can see where module 1 kind of started out with basic key concepts and practical strategies. Module 2 was more about speaking up within the healthcare system, creating a psychologically safe environment and team work issues, organizational issues, leading within the organization for different situations. Module 3 was more about working with the dashboard and about integrating social care into the delivery of healthcare, and then also about focusing on issues within the system. How could people take care of themselves, people who are providing care? How could they work to sustain some of the projects that they had already worked on? We had some special Helm sessions on the new hypertension guidelines in 2017, as well as the care of socially at-risk populations during COVID-19. And then the final module really focused on moving from Helm to Helm, which is what we decided is that this is a network, but we really are part of a movement, really moving forward to achieve health equity. So just some quick updates from the Rich Life Project. We've completed the care manager and community health worker interventions. We enrolled patients through August 31st. And then now we're going to be continuing data collection to follow how those patients are doing until August 31st, 2021. We're going to be doing this data collection for patient surveys by phone, and then we're also going to be getting electronic medical record data from the health systems. We do have some survey data that are being collected from health system partners, and we are writing manuscripts in collaboration with many of you. And we have a data safety and monitoring board meeting, which is going to take place tomorrow with our funders and an independent board that looks to make sure that we're conducting the study in a very scientifically and ethically sound manner. So I just want to close by thanking all of the members of this incredible research team. We have a very, very diverse and committed team. Of course, this study couldn't possibly be done without our health system partners. We're so grateful to all of you. Next slide, our community partners, all of you who are on this phone call, plus all of the organizations shown on this slide who have really, really helped to make sure that this study would be not only successful, it's not all done yet, but we've got some really, really promising results, and also come out with something that's really acceptable and hopefully usable in the long run to all of you.
So welcome everybody to our panel discussion. We have a terrific panel of presenters today, and they're going to offer us their perspectives on the Rich Life Project to date. What were the impacts of it? What pieces of it did they find most useful, and so on. So let me introduce our panelists. First, we have Susan Johnson, who is from Chop Tank. We also have Dr. Natalie Spison from Park West. We have Kara Bauer from Total Healthcare, and we also have Tammy Hull from Johns Hopkins Community Physicians. So I'll start by asking Kara, would you like to open with some kind of a opening statement?
So my name's Kara Bauer. I work for Total Healthcare and I'm their clinical educator. So my role in Rich Life is to really make sure that the staff is trained on how to do it, and then make sure they had the support of someone who had eyes on them, who understood how it was working, so that I could kind of advocate for how we were going to implement it in a way that worked for them and met the requirements.
Great. And did you have any specific takeaway from your experience in the Rich Life Project that you wanted to share?
I think that my takeaway was that it definitely was very important, but if you have something that's very important and all the staff don't see the importance of it, it's not going to be super successful. As time progressed and the staff really saw the importance of it, we actually had a much smoother experience. So it was very much a learning experience in that respect.
We are a federally qualified health center over on the Eastern Shore. very rural. So we were one of those interesting, how do you take something that might work in an inner city and translate it over to the rural population? Folks have different issues. When I started with the Rich Life at Choptank, my title was different. I was Vice President of Quality and Population Health, and was very much involved in population health activities. And the study seemed really exciting to me. I do all the measurement, and I knew we were not doing well with our hypertensive control measures. Got started with that. My role has changed a bit, and we've added some leadership staff. So I still have oversight over the Rich Life program, but we have a couple more leaders that have actually made things a little bit more robust at Choptank. The population health team, the care coordinators, are in my line of reporting. And so I still have my hands on them. They have a director who oversees them. And I will say that one of the things that I learned, sort of reinforced, is that it takes a long time. It's been like 3 years or something since we started this project. And in my mind, it seemed a no-brainer. This is just what you do. But learning how to implement a program across, for us, 5 health centers across 3 counties, which is 1,100 miles actually. Square miles is how big our service area is complicated. Turnover of staff. We had to really put in a lot of different structures to ensure kind of that continuity. And it just took longer than I thought it was going to take. We had some medical staff leadership change, which made it difficult. But we ended in a good place. And now folks are actually thinking, and COVID has sparked this a lot for us. Our medical staff are now thinking more about health disparities.
Hi, I'm Natalie Spison. I'm an internal medicine physician and the chief of adult medicine at Park West. And first, I just want to say that I'm humbled and shocked that you all showed a patient vignette from a patient of mine, and thank you so much, Ms. Cordova. So I'm going to just try not to cry right now, but just as far as opening remarks and kind of lessons learned, one, just that this was so prescient as far as enhancing home monitoring capabilities for patients before COVID. I think even just establishing the culture of that, I think probably we were not doing as much as we could have in just the basic ability to empower patients, or the belief in empowering patients to do monitoring at home instead of, just come in, we'll check your blood pressure and do med-rec, et cetera. And then the laser focus that it took on processes to start moving the needle, the enhanced kind of rooming process with their particular protocols for repeating measurements was something that I think that we were flagging on prior to Rich Life. And then the ongoing, unwavering attention to those processes, including the audits that came from the Rich Life team, were all really helpful in kind of continuing that culture of the laser focus on hypertension and the reminder that this is all disparities work.
So I would echo much of what has already been shared. We are a very large community group, and we're from Western Maryland to the Eastern Shore to Northeast Maryland. So again, we had some of the similarities of challenges across different environments, and each practice has its own kind of personality. What we did find was that it's so important to have buy-in from our leadership. Oh, and I forgot to say, at the time, I was the director of nursing practice and clinical education. I'm in a different role now. But so anyway, what we found was that it was so important to have the leadership at each practice, as well as, our bigger administrative leadership on board with the importance of blood pressure, because sometimes that can seem like just something you do, kind of like you take somebody's temperature, right? I mean, it's just something that everybody knows how to do that. And then we also had some challenges associated with getting the acceptance of the automated blood pressure cuff. And I think that stemmed from maybe previous experience and maybe, knowledge that was 20 years old, right? And experience that was 20 years old for people. So the Rich Life team was very helpful in helping to overcome some of that. And we've rolled it out to all of our practices now, not even just the ones that were on in the study. So thank you.
Well, thank you again so much for joining us. Thank you so much to all of the staff who helped to put this meeting together, particularly Nancy Malello, Gideon Avornu, and Devin Brown, as well as for Drs. Marsteller, Himmelfarb, and Cooper for leading us in such rich discussions and talking about the Rich Life Project and all of the great work that has happened. I can't believe it's been 4 years or 5 years since the project began.